Morning, everyone. Welcome to another presentation for Public Health 101. Today, we're going to be hearing from the Center for Health Promotion, Drug Overdose Prevention Program, and the Tobacco Control Program. So I believe Tara Cooper is speaking first. Tara, if you want to introduce yourself, and you can get started.
Sure thing. Good morning, everyone. Excited to be here and talk with you all about the work that we're doing. It's very dynamic work, and our team is incredibly passionate. So I think that's something that should be considered as we go through. There's a lot here, and we do a lot of dynamic and intersectional and cross-cutting work. So I think, without further ado, I'm going to try to share my slides and we can get started so that we can talk about all of the work. So I am excited to talk today about the Center for Health Promotion, and I will be joined today by Kirsten Skelly, our Tobacco Control Program Manager, and also Kathy Schultz, who is our Overdose Data to Action Project Manager. So when you look at our organizational structure, as you probably know at this point, the department has 6 divisions and very involved work in all areas. The Center for Health Promotion resides within the Division of Community Health and Equity. It's 4 centers as well as an Office of Maternal and Child Health. So again, there's probably about 125 to 130 employees that work in this division, and I'm going to get into the nuts and bolts of what we do. So, what is health promotion? Well, for some of you who may have are in school or have recently graduated or have degrees in public health, you all know that health promotion programs are focused on keeping people healthy. And our work aims to engage and empower individuals to choose healthy behaviors and also make changes that reduce the risk of developing chronic diseases. So here I have this definition of what the World Health Organization defines as health promotion. And I think the things that we think about is how individuals are able to increase control over their own health. And our job is to really address and prevent root causes of ill health and not just focusing on treatments or cures. A lot of the work that we think about is often connected to social determinants of health and how we modify risk behaviors in the work that we do. So we'll be talking a lot about that today. And we accomplish this work through communication, education, and policy, systems, and environmental change. So thinking about communication, we want to raise awareness about healthy behaviors, and that's done in a variety of ways, either through public service announcements, mass media campaigns, newsletters. Thinking about education, we want to empower behavior change and actions through increased knowledge. And then the policy, systems, and environmental change, we want to make systematic changes by improving laws, rules, regulations. That's the policy side. Thinking about how we make changes in organizational structures from a systems perspective. And then obviously thinking about the economic, social, or physical environment. There's 3 areas of focus that we're going to talk about today: violence and injury prevention, tobacco control, and overdose prevention. So here is our organizational structure. This compromises about 23 staff, either full-time state employees, contract staff, consultants from some of our universities. But here you can see the Tobacco Control Program is on the left, Drug Overdose Prevention Program, and then I also will be diving in to the Violence and Injury Prevention team and the work that they do. So again, the work that we do here is cross-cutting and intersectional. But if you think about how we approach our work, there's some principles that we really stick to. Residing in the Division of Health Equity, Community Health and Equity, we really want to promote health equity by thinking about and identifying problems within our systems and recognizing unjust conditions that may weaken the health of specific population groups. So we're going to address that and work with different population groups in specific and sensitive ways to address those health conditions that affect them. We do this again through effective communication of different strategies by disseminating targeted messaging and education to historically under-resourced populations. Some of the tenets that we really focus on is increasing public awareness and reducing stigma so that we can address misinformation and really endorse positive, affirming language in the work that we do. I know one of our programs, Kathy, can tell you that there's probably 23 different contracts in the work that they do in overdose prevention. So we partner broadly with multiple sectors and organizations, prevention coalitions, healthcare providers, universities and colleges, schools, you name it, we're trying to connect with them and even sort of the non-typical partners so that we can really have health in all policies in the work that we do. And again, our teams are going to talk a lot about how we collect and analyze public health data. And that is really, we want to guide all of our interventions and public health strategies using data. We want to know how big the specific problem is, where it's occurring, and who it affects. So keep that in mind as our team talks about the work that we're doing. And again, I know I said it's cross-cutting. We have a behavioral health crisis in the state. So when individuals are ready to come for treatment for maybe substance use disorder, we want to be ready. And if they are smokers, we want to be ready to help them quit smoking also. When we think about suicide prevention, we would be remiss if we weren't thinking about a broad coalition of sort of helping individuals with a variety of challenges that they may face. And they may also be using substances. So we want to be thinking about all that work and work across and break down silos. So I'm going to dive right into our violence and injury prevention program. What I'm going to describe today is the public health approach to violence and injury prevention, talk a little bit about the data, and highlight 6 areas that the team is working on. So, most of you know this, but public health focuses on the well-being of entire populations. And our job is to really understand roots of problems and then really think about how we can prevent it from occurring. And we know that, like diseases, injuries and violence don't happen by accident. They result from predictable convergence of human factors, a vehicle or an agent, with the surrounding environment. And the public health approach is really to carefully describe the problem through public health surveillance and data, study factors that increase or decrease risk for injury. Our team is involved with designing and evaluating intervention strategies to target those risk factors, and then really working with partners and state agencies to take steps to ensure that proven strategies are implemented. So instead of just focusing on treatment and individual injuries, the public health focuses on broad causes and prevention solutions. I have a dog that's going crazy here, so it's a little distracting. A comprehensive approach that we think about when we think about injury prevention is 3 E's: the environment, education, and enforcement. So if we just think about motor vehicle crashes, there are many strategies that are work from a prevention perspective. If we think about the environment, things that we look at is how can we make our cars safer? How can we make our roads safer? Is there a certain neighborhood or an intersection where more crashes occur? Thinking about the other E, education. How do we encourage and educate individuals about transportation safety, around seatbelts, avoiding impaired driving or distracted driving? And then the other E is enforcement. And so, making sure that we in a state are really, have checkpoints for, impaired driving, that folks are using their seat belts, and that we can discourage the risky behaviors that often occur. Our team on violence and injury is small but not mighty. There's about 9 individuals, again, that work in a variety of ways. And they manage 9 federal grants totaling about $2.8 million. So the team is very involved with federal grants. And we have several coordinators working in areas. And I'm going to dive into a little bit more of the details of what this team is working on. So, one of the first areas of focus is injury prevention, and we get some federal dollars to focus on state injury prevention. And in our current grant year, our current grant, 5 years with the CDC, we're focused on prevention of intimate partner violence, child abuse and neglect. I sort of alluded to preventing motor vehicle crashes and traumatic brain injury. So we've been successful in, partnering with, again, community-based organizations to implement strategies that really address the upstream risk and protective factors that would have the greatest potential for impacting violence and injury outcomes. So 2 of our recent successes include the implementation of the Rhode Island Middle School Emotion Regulation Program. And we also have developed a Rhode Island concussion management manual for schools also. So thinking about what the emotional regulation program is set to do, it's a school-based peer group program that's designed to enhance middle school's ability to apply emotion regulation skills. And that's really focused on trying to decrease risk behaviors related to interpersonal and sexual violence. And I would tell you that our evaluation findings are really promising and show that emotion regulation can be and is positively associated with improved attitudes about dealing with violence. And again, I'm going to talk a little bit about our concussion management approach, but we have a state-of-the-art manual and tools so that we can really partner with school nurses and principals and school administrators so kids can return to learn. So you may say, well, why do you do this work? We know that Rhode Island data show that we're seeing a significant increase in the last several years with motor vehicle crashes, and the age groups that are most significantly impacted are the 15 to 20-year-olds, as well as 75 years and older. And so most of our motor vehicle crashes or accidents involve speeding or not wearing a seatbelt. So we have some work to do, and because of this data, we partner closely with the Rhode Island Department of Transportation, Office of Highway Safety, and the Department of Motor Vehicles to create and disseminate transportation safety education messages. And again, as I mentioned before, data drives our work, and we're always looking to enhance the work through existing or exploring novel surveillance systems to do this. Traumatic brain injury prevention and person-centered programs, is a project that we've been working on for several years, and we know that in the last 5 years, about 14,000 emergency department visits and about 3,000 hospitalizations occurred due to unintentional fall-related injuries. And we also know that our emergency department data show that 43% of TBI or traumatic brain injury related visits were due to falls. A smaller number were due to being struck. 18% were due to motor vehicle issues, as well as 8% due to assault. So the team is really focused on creating and strengthening person-centered, culturally competent systems of services to really maximize the independence and overall health and well-being of people with TBI across the lifespan, as well as helping family members with resources. And we're doing this in a variety of ways, but expanding our TBI registry in our hospitals here in Rhode Island and exploring other surveillance systems, enhancing our current TBI advisory board, and we've updated our action plan, and we're currently working on an infrastructure sustainability plan. Again, I mentioned the work that we're doing on concussion return to learn protocols, And, we are fortunate that we're able to work with the Brain Injury Association of Rhode Island, to work with a patient navigator to really conduct public outreach and make sure that individuals who are impacted by TBI can really be linked up to support services. Suicide prevention. I'm going to dig right into the data. What we know here in Rhode Island is that we have about 120 suicides a year. And that was probably in 2020. We had about 1,000 emergency department visits and 500 hospitalizations for either suicide ideation or an intentional self-harm. We see deaths across the lifespan. I shouldn't say that. Fewer deaths occur in young children or young adults, but we do see more impact in our middle-aged population. So, middle-aged adults. But I would just tell you that currently we do not have any dedicated state funding or federal funding to address prevention in the adult population. Um, so it's really the work is really focused on youth and in the age group of 10 to 24-year-olds. And this is important because we do see with Rhode Island YRBS data that there's a proportion of our middle school and high school students that feel sad or hopeless, and that we do know that around anywhere from 13 to 17% of our students in middle schools and high schools have seriously considered suicide. So, one of the main goals of our youth suicide program is to divert at-risk Rhode Island public school students from unnecessary emergency department visits by being able to connect them to local mental health services. And that we collaborate very closely with school student counselors and school personnel. We've also implemented a multi-campus college mental health social media campaign, and we are very involved and have been for the last several years on a state initiative to prevent suicide among service members, veterans, and their families. We also have recently created a comprehensive suicide prevention website, similar to what our friends have done in the overdose space, and we are currently working on a state suicide prevention plan. So a lot of good work is happening in this area. And just sort of connecting the dots, thinking about mental health, we know that almost 1 in 5 Rhode Islanders have mental health or mental health challenges. And we know that behavioral health or psychiatric emergencies are the second highest reasons for ambulances or to have an EMS response. And that we know that anywhere from 7 to 9% of our active service members do experience either depression or PTSD. So over the past 3 years, we've been able to implement a comprehensive training program to increase the ability of our EMTs to respond to individuals experiencing a mental health crisis. In addition to training the target population, we're also training family members of current or former military service members to recognize and respond to signs of mental distress. Still focused on the violent side of the house, we know that 1 in 5 women and 1 in 7 men will experience rape at some point in their lives. 1 in 4 girls and 1 in 6 boys will be sexually abused. We know that women of color and members of the LGBTQ population or community experience higher rates of sexual violence. So we have a rape prevention and education program. We partner with 8 different community-based organizations to implement a range of activities that address ways that the individual, relationship, community, and societal factors can really make an impact on decreasing sexual violence. The team has been able to create a sexual violence prevention coalition. We've been able to fund the Trans Action Coalition to support trans protective policy and system changes here in Rhode Island. We support youth leadership and civic engagement programs in our core cities. We have implemented a certified peer education training for sexual violence in high schools and higher education. And we recently just had more than 45 individuals and some from school personnel be trained and certified in Title IX, so that they can launch investigations if needed in our K-12 schools. And the last area that I will focus on is thinking about maternal mortality. So violence is a reality for individuals who have either who are pregnant or have recently given birth. And so we know that intimate partner violent rates with our PRAMS data here show that anywhere from 4 to 5% of women who or individuals who have given birth are impacted. And we know that women under the age of 25, racial and ethnic minorities, and those who are uninsured experience higher rates of intimate partner violence. So what are we doing? Here in Rhode Island, we're partnering with the Federal Office on Women's Health to develop and implement interventions to really reduce maternal deaths due to violence, specifically homicide and suicide. And we're using emergency department syndromic surveillance, and we are also looking at deaths in individuals who have recently given birth or who are postpartum, and really understanding what happened through a mortality review. We are partnering with Sojourner House to implement an intervention called Mosaic, or Mothers Advocates in the Community. And we're also making connections and expanding referral pathways at Women and Infants and through our family home visiting program, so that we can reduce and prevent violent deaths among pregnant and postpartum women and really provide them with the support that they need to thrive. So I am going to stop there. And I think rather than take questions, in the interest of time, so that my colleagues can continue, I am going to turn it over, I believe, to Kirsten. Are you going to go? All right. So
Yes.
now you're going to learn all about tobacco control. And then our friend Kathy Schultz is going to enlighten you with all of the amazing work that we're doing in overdose prevention here in the state. So Kirsten, take it away.
Righty.
And sometimes the hardest part is pulling up Teams or if you're on a Zoom call.
All right, I'm back. My Teams is not a big fan of PowerPoint, so hopefully I can get through this without any issues. So let me see here. Oh my God. Okay. All right. So everyone can see my presentation, correct? Okay, good.
Yes.
I'm still on the call. Happy about that. Okay, so good morning. I'm Kirsten Skelly, the program manager at the Tobacco Control Program. I do want to start this presentation by defining tobacco that's not only used in this discussion, but within our program efforts. And it refers to the commercial tobacco, which is manufactured by companies for recreation and habitual use, and is different from the sacred traditional ceremonial tobacco that's used by Native American tribal communities. So the majority of our funding comes from our CDC cooperative agreement with the Office of Smoking and Health, which mainly dictates how we do our activities and how we are structured. So for full-time staff, we do have myself as the program manager. We have Heidi, who works with policy liaisons for the program between community partners, legislation, and other statewide prevention groups. Ashnita's role oversees both surveillance and evaluation, and then Jillian works within our community and school-based organizations, focusing on youth engagement and education. And then we have Julia, who oversees education and improving access to the statewide treatment resources and manages our state quitline contract. In addition, we do have support from communications in the form of a fully dedicated communications coordinator, and they will oversee all aspects of our media reach and internal and external communications. And then finally, because of our cooperative agreement, we do have access to national partners that do assist us not only on technical assistance, but with the community reach, and they are listed here. So in 2019, a strategic plan was formed with the community partners, and during this planning came the goals, which are listed here as well, and the mission of our program. And the mission is to protect and promote health, prevent chronic disease and death among all Rhode Islanders using a comprehensive approach to reduce tobacco initiation, use, and exposure to secondhand and third-hand smoke. So next, let's look at what drives the focus of our activities. So here's a snapshot of the cost of tobacco use in Rhode Island. Approximately 800 Rhode Island adults die a year from smoking, with about 150 adults, children, and babies dying each year from other smoking, which is secondhand, third-hand smoke, and pregnancy smoking. And 16,000 Rhode Island children currently under 18 will ultimately die prematurely from tobacco-related illnesses. In Rhode Island, each year, about $640 million is spent on healthcare costs caused by smoking. So some key understandings of tobacco and nicotine use are that it kills more people each year than car accidents, homicides, suicides, drug overdose deaths, and HIV/AIDS combined, and accounts for about 1 in 5 deaths each year. It's also responsible for roughly half of smoking patients' deaths. Exposure can cause and worsen conditions and cancers in every organ of the body. In addition, it is linked to infant mortality due to it causing birth defects, premature birth, and underweight births. When discussing nicotine exposure specifically, there is a link to stunted growth in adolescent brain development. So secondhand and third-hand smoke, along with tobacco and nicotine use, are especially harmful to pregnant women, infants, children, teens, elderly, pets, and anyone with other chronic conditions. So before starting the next slides, I do want to list here some of their tools and resources that we use within the program to help with the surveillance and evaluation of use throughout the state. And that helps to help make us do the data-driven decisions on best practices and identify the program gaps that will help us focus our program activities. So now let's look at some of the trends that we see nationally and within Rhode Island regarding tobacco and nicotine use. So again, with the next few slides, I'm not going to go into much depth with them, but rather just highlight the trends that are concerning to us and that we look to address with our current activities. And I do also want to say going into these slides to understand that we recognize that social, environmental, and economic structures shape the usage outcomes seen here and not reflective of the individual. So what I want to highlight on this particular slide is that nationally, the preference among youth is for e-cigarettes. E-cigarettes entered the U.S. marketplace around 2007 and since 2014 have become the most commonly used tobacco product among youth. And that use among the middle school and high school students increased about 900% between 2011 and 2015. And like the national level, we do see in Rhode Island, the use preference is for e-cigarettes as well. Here we get a look at the preference of products of use among adults compared to high school and middle age students. The first two groups on the left show the cigarette use, while the other three to the right focus more on ENDS use. And ENDS refers to electronic nicotine delivery systems, which are vapes, e-cigs, and such. The concerning trend that we see first are that there is an inverse relationship between adult and high school preference for e-cigarettes versus the ENDS use. So for cigarettes use, we look at adults, which is the green bars, are more likely to be ever smoked, meaning they used in the last 100 they used at least 100 products in their life, and current, which is they used once in the last 30 days. Whereas we see high school, which are the orange bars, are much more likely to be ever smoked and current smoke for ENDS users, and at a higher percentage than when compared to the adult cigarette use levels. And that also that 10% of high school students are reported as current frequent ENDS users, meaning that they've used 20 out of the last 30 days. And finally, middle schoolers, which are the blue bars, are reporting similar ENDS use levels as adult ENDS users, which really demonstrates the fact that children, even in middle school age groups, are exposed to tobacco and nicotine products. So when looking at Rhode Island adults specifically, individuals with behavioral health conditions have some of the highest rates of use of both cigarettes, which are the blue bars, and ENDS, which are the green bars, when assessing behavioral health conditions by proxy measures of mental distress and heavy drinking, which are the top two groupings on this slide. Below those, other key disparities exist amongst those with socioeconomic status, using the measures of Medicaid, low income, less than high school education lines, groupings, which are in the middle. And then further down, the grouping we see is those that identify as lesbian, gay, and bisexual. Trans was not included here due to a potential data error. But of note, those who identify as lesbian, gay, and bisexual are shown to have ends use, again, those green bars, that are similar to those of the measures of frequent mental distress and heavy drinking. So looking at Rhode Island youth disparities, we see the similar trends like we saw in the adults. Increased ends use with those who are reported as current mental health as not good and considered attempting suicide in the last 12 months, which is the orange and the dark blue bars. Increased and then also increased use with those that identify as LGBT, which is the yellow bars, and with grade level, which are the blue bars at the very top. So now that you see why tobacco control is important, let me share with you what we're doing in Rhode Island. So keeping in mind the previous slides that outlined the problems in the state, our activities focus on reducing use and initiation in the youth population, excuse me, the LGBTQ plus population and behavioral health populations, along with expanding the capacity of our state-sponsored nicotine helpline, reducing access to products using commercial-based level tobacco control capacity, increasing local level data collection, and improving community and retailer education. Our initiatives of the program are formed in those PSC or policy system environmental change strategies that Tara mentioned previously because of their proven effectiveness in reducing tobacco use. These strategies create that ongoing and foundational behavioral change over time and creating capacity for these changes to become long-term and sustainable. So listed in this table are some activities under each change strategy that we have supported in the past, hope to continue to support, or are actively pursuing with our program. So our more recent policy strategies include supporting legislation, fiscal measures, taxation, and regulatory oversight. The next box lists a few of our current system change activities. These areas refer to a fundamental shift in the way problems are solved, so affecting function and connection by addressing the culture, belief, relationship, policies, and goals. And then the last box lists some environmental change strategies that involve changing the economic, social, or physical surroundings or contexts that affect health outcomes. So we exist to link tobacco control from the national level to state and local levels to make our action sustainable and encourage the community engagement. So by supporting local partners that have similar goals, we hope to leverage these current structures and align resources for this effectiveness and efficiency. So listed here are some of the partners that the program does work with within the state and local community. And these partners were the ones to bring the community voice to the table when we completed our most recent strategic plan. They've been part of the discussion for policy building and program activity. And have assisted with the promotion of equity, information, and education within the community. So in addition, these partners have helped to lead some of the state policy changes listed here. The most recent, which isn't shown here, is the Tobacco 21 legislation, which was signed into law on July 7th, 2021, making it illegal to sell to anyone under 21 and also aligns us within the federal law. So other highlights shown here include the Rhode Island Smoke-Free School Act and later the ENDS ban in schools, the Tobacco Master Settlement Agreement, and HUD mandating smoke-free housing. On a side note, most recently, we did provide public comment on the FDA proposed rules banning menthol in cigarettes and characterizing flavors in cigars, noting that the historical marketing of menthol cigarettes to high-risk groups, especially populations of color, those who have identified as LGBT, and adults who smoke and have had mental health conditions. So with the purpose of reducing the use of smoke and nicotine within the state or initiation, it is expected that we also look to promote cessation or quit support programming to help those that won't be smoking. So to improve successful quit attempts, we look to provide easier access to resources and education on evidence-based cessation treatment, particularly those populations that show a disparity of use or actually lack access to these resources. So some of the activities here are listed here, and our top focus is promoting best practices for screening and referring with electronic health record integration with our state nicotine helpline, with the providers. This will provide a workflow for screening, brief intervention, and referral to the state helpline with easier feedback to the provider on their client's progress. Additionally, we're looking to help behavioral facilities move to be smoke and tobacco free. Listed here are some of the barriers of why that has not been a change in the past. And with it, we are working with facilities to train the staff on best practices, establish a workflow for screening, documentation, and referring. And in addition, we are using Medicaid billing data to build evidence on improving billing and reimbursement policies and practices in screening, and potentially making a case for co-sponsoring cessation services. A year ago, we did also host a SAMHSA's Tobacco-Free Recovery Summit, which brought together the various state and local community partners to discuss tobacco control in behavioral health facilities, which led to 4 focused statewide groups that are currently ongoing, which is policy, data, education, and system change, equity, and access. Also, we are looking within the correctional facilities to offer in-house group counseling in the minimum security facility, train community outreach officers in hopes to connect inmates to resources in the community once released, provide access to the nicotine replacement therapies through public health focused vending machines within the facilities, and hope to provide in-house screening for those that do use. So finally, we also, within our cessation program, is the promotion of the evidence-based quit resources, and one being our state-sponsored quit line. It's the Rhode Island Nicotine Helpline, which I'll discuss in the next slide. So here's an overview of our state-sponsored Rhode Island Nicotine Helpline. It is free to use, provides individualized quit support for tobacco and nicotine use dependents, also provides self-help materials, and if medically eligible, nicotine replacement therapy. More recently, there was from there the My Life, My Quit line, which is still part of the Rhode Island Nicotine Helpline, but it is focused mostly on youth. It's newly established and focuses on the ages 13 to 18, and it is a tailored program for youth with content about vaping, and they can do text by phone, chats, or text or live calls with youth coaches, and the promotional and educational materials are designed for teens by teens. It's essentially one of the only helplines in the state like this. So with our youth and young adult programming, listed here is the youth focused programming 3-prong approach. And within that approach, our activities in this area are working with Youth Ambassador Program in partnership with our community lead agency to help with peer-to-peer and local community education, promotion of that My Life, My Quit Rhode Island Nicotine Helpline, to help also promote the Rhode Island Smoke-Free Model Policy in K through 12 schools. And then we are currently working with the Regional Prevention Coalition and the LGBTQ plus youth in South County area to affect the community change and address those disparities of use among this population. And then finally, we're focusing now to look to assist colleges with having fully tobacco, nicotine, smoke-free campuses. And finally, one of the key parts of any successful control program is communications. We need to reach those where they are at and provide the most accurate information and education on current policies, available resources, and the effects of change. So here are a few examples of our community reach in multiple languages. These images were pulled from a few different platforms like social media, billboards, print media, and handouts. In addition, you may have seen our local ads marketing the CDC Tips campaign. Incoming calls during the state helpline during the 2020 Tips campaign increased by an average of 77%, so it is effective. Communication also helps with designing marketing toolkits for providers, parents, and schools, and provides that technical assistance for community partners who want to design their own medias and campaigns. So this completes the overview of the program, and I do want to thank you for having us. Now I believe Kathy Schultz will be speaking on the Drug Overdose Prevention Program.
Thank you, Kirsten. Kathy, we're ready to hear all that you are doing, and there's a lot.
Can you see do you
Yes.
see the slides?
Yes.
Okay. I have to, yeah. Hold on one second. I'm just trying to pull the screen up so I can see you all while I'm doing this. Okay. You can still see the slides?
Yes.
Okay, perfect. Let me see if I can get this to be a slideshow. Is it now a slideshow?
Yes, Kathy. It looks good.
Perfect. Thank you. Hi, everybody. My name is Kathy Schultz. I'm a project manager here in the Drug Overdose Prevention Program. I oversee the mobile outreach projects and several other of our projects here in the Drug Overdose Prevention Program. And so I'm going to start off with the purpose of the Drug Overdose Prevention Program. It is to develop, implement, and evaluate comprehensive state and community level interventions for preventing drug overdose and ensuring access to treatment and recovery support services. And so here are some of the objectives. Why is the Drug Overdose Prevention Program important? How does the DOPP, that is our acronym, use non-fatal and fatal overdose data to inform state and local responses? And what are some of the prevention strategies, as well as some resources in the last couple of slides? So why is drug overdose prevention important? I want to start off with this, and I like to typically do this. I heard about health equity or racial equity in our tobacco presentation, and I always try to start off almost everything and kind of bring that to the forefront before I even go on any further with the presentation. It's really important to remember that our BIPOC community is disproportionately impacted by all health disparities, many health disparities, including overdose. We have found in our data, I can't quote all of the numbers or the percentages, but they are being disproportionately impacted by the overdose epidemic. So I just wanted to say that up front, and so that we can move forward, reminding ourselves to have a racial equity lens as we go forward. So here are some of the national and regional trends. These are just some clippings, and I tried to bring some newer ones from as soon as, the most recent. Here in the state of Rhode Island, we have had a 22% increase since last year, which was an increase from the year prior to that. COVID-19 has directly impacted in many, many areas of health disparities in overdose specifically. So driving data driving action. So I just wanted to give you a couple of pieces of some of the data that we use to drive the action that we do use in our drug overdose prevention program. In review of RIDOH's integrated surveillance system, non-fatal overdoses, to learn about patients receiving care from emergency department or emergency medical services for suspected overdoses, opioid overdoses. You can see where it says integrated surveillance system. We also use maps and we look at heat maps so that we can find where some of the hotspots are. And finally, we send out ROARs when there are communities that are above a threshold. And I have some maps to show you a little bit more about that, and we can talk further. Here's an example of one of our ROAR region threshold that are over threshold. So in other words, a public health alert will go out and for the region that is impacted with increased activity. Their thresholds are set based on data from a year prior. And if it is over a threshold, the ROAR will go out. There are 10 regions in our state and also an unknown. As you can see here, this is region 10. And this is what the ROAR alert looks like. Now, this ROAR alert will go out to several key stakeholders. The next slide will give you some of the names of the stakeholders. And as you can see, it's timeframes for 1 week. And this shows that region 10, which you could see in the map prior, which was in our southern Rhode Island area, Westerly, Charleston, Narragansett, New Shoreham, North Kingston, and South Kingston were over their threshold. And therefore, a ROAR alert was sent out. And as you can see here, these are some of the key stakeholders that get these alerts: public health and healthcare professionals, first responders, our harm reduction organizations, municipal leaders, the health equity zones, community overdose engagement, the code communities, collaboratives, and community partners, and more. So basically, here at the Department of Health in the Drug Overdose Prevention Program, we actually have harm reduction organizations that are funded through our OD2A grant. We also have the code communities, which are also funded through our OD2A grant. And that actually is in partnership with our health equity zones here at the Department of Health. And so here is just a little summary of where the action plans come from, where they were created, where the strategies actually in our state overall began. So in December 2015, the task force, the governor's task force on overdose prevention and intervention, was established, and an overdose action plan was developed. Since that time, it has implemented strategies in 6 complementary areas, which are prevention, harm reduction and rescue, treatment, recovery, racial equity, and the family task force. And here are some in the Department of Health. We partner with our other state agencies, BHDDH, EOHHS, and many other state agencies in a lot of all of the work that we do. But one of the initiatives that we really focus on is harm reduction. Harm reduction is a public health approach to overdose, to reduce negative consequences of drug use. So one of the grants that I talked about, or one of the programs that I talked about a little bit, was our targeted mobile outreach to overdose hotspots by peers. That is actually the program that I manage. The centralized naloxone, Narcan, and harm reduction hubs. That is very a partnership with BHDDH, as well as URI and a couple of other community partners, Pony, where we actually are funding harm reduction hubs to centralize where naloxone, Narcan, and also harm reduction supplies are being ordered and tracked. Naloxone administration training to professionals and community partners, publicly available naloxone, nalox boxes, harm reduction center legislation and regulations, the community overdose engagement efforts code. This funds, this provides funding directly into high burden communities. Right now we have 3 communities, which is Providence, Pawtucket, and Woonsocket. Cross-division collaboration. We work very, very closely with all of these different programs or departments here at the Department of Health. Surveillance, as you saw with the ROAAR alerts and you saw with the maps, that all comes from our surveillance division, and they work hand in hand with us so that we can actually put data into action. We work very closely with our HIV. I know it's a big long acronym, a big long name, so I just call it HIV. And basically, I work closely. I meet with their team bi-weekly. We look at the metrics for our harm reduction initiatives that are funded through the Department of Health, and we work and we're make sure that the metrics line up, make sure the definitions work with our community partners. Communications, everything that we do, even these slides were overlooked by were looked at by our communications. We work with the health equity zones, as I mentioned earlier, and our prescription drug monitoring program. Our drug overdose fatality review. I wanted to highlight this a little bit because this is something that's really important. This is where we're looking at the fatal data. We do look at the fatal data as far as maps and heat maps and so on and so forth. But in addition, they take a really deeper dive into the fatalities. The objective is to identify systemic and community level gaps. It's a multidisciplinary multidisciplinary team. It's legislatively mandated. It's funded by the Centers for Disease Control, again, the OD2A grant, and information about individuals is de-identified and protected. So basically what they do is they meet, they look at the specific areas or they look at the individual, and then they come up with recommendations on some of the responses that could be implemented throughout the state. And finally, I wanted to just note this a little bit. Recently, many of you probably have seen or heard the state of Rhode Island, the Attorney General's office actually was just settled $192 million in opioid abatement programs. 80% of that is going to go to the state. That's 148 million. And then 20% is going to go to the local communities or local municipalities. And that's 39 million. And this will be spread out over 18 years. And one of the things I mentioned a little bit earlier, a community overdose engagement or a code initiative is actually providing some workshops, and I wanted to just share some of these dates here. This is targeted for municipal leaders, but this is very important. This comes directly from that local response that our code project uses, and this will provide some guidance and offer using overdose data to drive action, stigma and its impact, and data-driven initiatives. And before I go into the resources, I also wanted to add, and I know that it was said a little earlier, about stigma. So here, in my role here at the Department of Health, along with one of my colleagues, Heather Seeger, we developed a stigma training, and that stigma training will be presented for the TA sessions or the workshops. But we also at Public Health 101, there is actually going to be a stigma training on September 15th from 9 to 10. If anybody's interested, we would highly encourage you join us. This can give a little bit of a better idea of how stigma impacts, why stigma exists, how it impacts, and what you can do to help to reduce stigma. And finally, here are some of the resources if you have any additional questions. That was a lot of information. I know we don't have a lot of time, so I wanted to try to get through the slides and make sure that I was able to give you an overview. You can go to our Prevent Overdose RI, and any of these resources can be found there, but here are some specific links to some of those resources. We have our harm reduction centers. You can take a look at a one-pager as well as the legislation, provide patients with harm reduction tools. You can order naloxone. Anybody can order naloxone. There's an actual link to order that. COVID-19. This is the one they call it. It's still listed as COVID-19, but I find this to be the most localized harm reduction resources. Connect patients to community-based harm reduction organizations. Refer to BH Link or the buprenorphine hotline for addiction treatment. And if you are interested, you can look at some of the provider resources in our pathways. And with that, I will end there and try to find a way to stop sharing. If I can find the button, there we go. Okay.
Thank you so much, Kathy. I think, as you can see, our three teams are involved in a public health alphabet soup of work. And if they hear of an opportunity, they are looking to engage. Again, a lot of our grants are federally funded and help us provide the scope, but they're always encouraged and willing to partner in any of these three areas. So, Jen, I don't know if you usually solicit questions. It looks like we were able to finish up with a little bit of time to spare. I don't know if the folks here have any questions about the work that we are doing in the Center for Health Promotion.
First off, that was very impressive, all that information in 1 hour. Amazing, and so much good information I personally have never heard about these programs in depth, so it was super interesting. Does anyone have any questions? Feel free to write them in the chat or just come off of mute. And then if not, we can kind of wrap up.
As I said earlier, next year when we do this planning, it's obvious to me that each one of our teams could easily occupy a full 50 minutes of work. So kudos to Kirsten and for Kathy and for the teams who have contributed to the presentations so that we could get and give you, whet your appetite, as I like to say. But in the future, we definitely have a lot to share and a lot of dynamic work that's happening in the center that we would be willing to dive more into detail with.
Great. All right, I don't see any questions. Thank you all so much. This was a really great presentation.
Thank you, Jen, for the opportunity.
All right,
Have a
bye-bye.
great Monday.
Bye.